friends. So now we're beginning with cardiovascular system in an integrated fashion, in which we are going to be talking about CVS physio, we are going to be talking about CVS medicine, pharmacology, and the most dreaded thing ever is ECG. So that's what we're going to be starting off with, so that we can get it out of the way at the very beginning, and then we have other stuff which will hopefully seem easier after that. So let's begin then with CVS. Before we start with ECG, we need to understand the action potential, and if we understand this, then anti-arrhythmics becomes much more simpler, which is again something which is a very difficult topic. So let's try and understand first the action potential of a normal myocardial cell or a myocyte, and then we'll talk about how it is different for the pacemaker. Okay, so in a normal myocardial cell, the resting membrane potential is somewhere around -85. Okay, we'll talk about this, how this is maintained. But whenever depolarization is happening, it's like any other cell, there is going to be depolarization with the help of inward movement of sodium. So anytime sodium moves in, there is going to be depolarization. Okay, so this is what you want to remember. In phase 0, sodium moves in, and that is why overall positive charge, simple, all overall positive charge is coming in, so the potential moves upwards, there is depolarization. And then there is this short phase. This is very unique. This is very unique to heart. Here you have this slight repolarization that happens in phase 1 because of some potassium which is trying to go out. Alright, so some potassium goes out, potassium efflux happens, and that results in a slight repolarization. But then what happens? But then our hero calcium comes in, and calcium is like, I'm gonna save the day. So now in this plateau phase, we have two things which are fighting. Look at this. We have potassium who's trying to escape and let the positive charge go outside, but then there's calcium who's coming in and saving the day for us. So this results in this phase 2 for plateau. So this results in plateau phase. So plateau phase is a result of potassium and calcium. But eventually the calcium just gives up. It is not able to fight the ever so powerful potassium. So what happens now? The potassium wins and it is persisting. So this also tells us how persistence will lead to great results, isn't it? So it persists, and that is why eventually the repolarization happens. Again, how is this negative phase maintained? Negative phase is maintained by potassium, the persistent ion. Okay, so this is what you need to remember. So essentially potassium is everywhere except for depolarization, when sodium predominates, brings the positive charge, and the calcium balancing it. Okay, so this is how action potential is maintained. Now what happens in the SA node, or what happens in the pacemaker? In the pacemaker, phase 0 is the real difference. So this horizontal resting membrane potential here is not horizontal. So who is responsible for this is the most important funny sodium channel. So we call them funny sodium channels because the name is sodium, but it does two things. It is balancing out two channels. It is balancing out the inward sodium movement and outward potassium movement. Alright, so let's just say this is the cell, sodium coming in and potassium going out. So it's balancing both of these. Okay, so this is inward movement of sodium and outward movement of potassium. So the funny channel regulates both of this. Apart from this, you also have the T-type calcium channels. So you want to remember a mnemonic here, funny cat. Two things are responsible for this pacemaker resting membrane potential that is shifting towards depolarization. This delayed depolarization that is happening is because of this funny cat. Calcium ion channels which are T-type and funny sodium. Alright, so this results in this slow depolarization. Eventually, who is responsible for depolarization? The phase 0, very important, is now calcium. It's not sodium, but it is L-type calcium channels. Alright, and then you have again the hero, the persistent potassium coming in and repolarizing the cell. Okay, so this is what you need to remember as far as the phases are concerned. We'll apply this. Now, how acetylcholine and adenosine actase, they reduce this phase here. They reduce this phase here and they slow it down, and that is why they are able to reduce the heart rate, whereas catecholamine will increase the heart rate by accelerating and shortening this phase of depolarization. Okay, so this is what you want to remember. Now let's go to antiarrhythmics, their mechanism of action, and how questions can come, particularly in NICT, is what they do to the graph of the myocyte action potential. So that is the applied concept. For that, you need to have understood what we have just done. So first I'll tell you the classification of antiarrhythmic drugs is also known as the Vaughan classification. So in type 1, you predominantly have all of the sodium channel blockers. So you have sodium channel blockers in class 1. In addition, they do something to potassium. So 1A is your potassium blocker, 1B is your potassium opener, and 1C has no effect on potassium. Alright, so now before we go to 1A, 1B, 1C, if I have to look at all of these three graphs, can you say something which is common to all of them is the phase 0 slope has reduced? The phase 0 slope has reduced because of the sodium channel blockade. That results in this depolarization being slow. Yeah, so I hope this is clear that the slope of phase 0 when it is reduced, that is indirectly telling me that you are dealing with a class 1 drug. So that at least that much I can identify. Alright, so they can give you this graph and ask you which drug are we talking about. Okay, so phase 1 is sorted. So far so good. Okay, now anytime potassium channel is blocked, the ever so persistent potassium who's trying to cause repolarization is blocked, what do you think is happen? There's going to be a delayed repolarization, isn't it? Calcium is going to fight much longer. So now can I say that this action potential duration, this is the total action potential duration, that increases? Yeah, so what happens in 1A is this action potential duration increases. Okay, so this is what we learned, that whenever potassium is blocked, that is 1A channel, you are gonna have high APD. Can I also say the QT interval gets prolonged? And that is why this is one of the drugs that can cause a long QT syndrome. Okay, so remember this 1A. On the other hand, if potassium is opened, somebody is fighting in the team of potassium. Now what's gonna happen? Look at the blue line. The blue line is shortened, the action potential duration is shortened, the QT interval is shortened. Is this clear? So this is 1B, and when nothing changes, it remains as is, it is 1C. I hope this is clear. Now the examples. So 1A is, you want to remember, the queen proclaims Deso's pyramid. That's the sentence. The queen is proclaiming that Deso's pyramid is my pyramid. So queen, quinidine, proclaims procainamide, Deso's pyramid. Okay. Potassium openers are your lignocaine and phenytoin. Very, very important. Lignocaine, remember, is the drug of choice for ischemic arrhythmias as well as because of digitalis. So digitalis and ischemic V fibrillations or arrhythmias, the drug of choice becomes lignocaine. 1C is flecainide and propafenone. You can remember, please pass the fries. Okay, slightly you can remember. Please pass the fries. So propafenone and flecainide. What is class 2? Class 2 are your beta blockers. We have seen how beta blockers are going to slow down the phase 4. Yeah, so they're going to effectively cause a reduction in the heart rate, a reduction in the myocardial oxygen demand. What does type 3 do? Type 3 are your potassium channel blockers. Okay, so these are potassium blockers. So when I look at the graph, look at this graph here. You see that sodium is as is, but the action potential duration is again increased. So this is again going to prolong the QT. So there are two groups of drugs which can cause long QT syndrome, which can predispose long QT syndrome. Remember them together. I'm writing at the top of the page. Very important. Class 1A, class 3. Anything which is a potassium blocker effectively causes this fight to be longer, and that is why this is going to be predisposing to long QT syndrome or torsades de pointus. Okay, so that's how we remember. In class 3, what we have is AIDS drug. You want to remember AIDS: amiodarone, ibuletide, dofetilide, and sotalol. So AIDS drugs, out of which amiodarone is very, very important. The side effects are very important. So you want to remember, please check PFT, LFT, TFT. So please, because this causes photosensitivity. You want to remember, check because this causes corneal deposits. PFT because this causes lung fibrosis. We'll also do this in general pharmac. LFT because it is hepatotoxic, and TFT because ioda. Can you see IOD here? This has 40% iodine, and that is why it can cause hypo or hyperthyroidism both. When excess iodine causes hypothyroidism, that's known as Wolff-Check off effect. Do you remember this? We've done it in endocrine. So Wolff-Check off. Off means hypothyroid, whereas Jod-based do is hyper. Okay. So this is about the side effects of amiodarone. Class 4 is nothing but calcium channel blockers. Apart from this, in amiodarone, you also want to remember there is P for pigmentation, which is also known as ceruloderma. So it causes this dermal pigmentation, which results in bluish nature. So this is ceruloderma as well. Okay. Now coming back to class 4. So class 4 is your calcium channel blockers. Alright. So calcium channel blockers, as you know, will decrease the plateau phase. Okay. Now let's talk about adenosine. So adenosine is the shortest acting drug that we have. It has only one cycle of metabolism around 11 seconds. So this is the shortest acting drug which is there. Adenosine has two mechanisms. Adenosine reduces the calcium and it also increases the potassium efflux out of the cell. Alright, so these are the two functions that it does, and this is one of the drugs that we use in supraventricular tachycardias, PSVT, in stable patients. If the carotid sinus massage doesn't work, we're going to be using adenosine. Okay, but one thing very important is adenosine's action can be blunted by theophylline and caffeine. Both of those are adenosine inhibitors. This I've also taught you in respiratory pharmacology for asthma. So this is very important and tested a lot. Okay, so this is all about anti-arrhythmic drugs that you want to remember. So highlight is 1B, even though this is a drug of choice for ischemic arrhythmias, remember 1C is contraindicated in ischemic arrhythmias. Alright, so 1C, CI is contraindicated in what is the drug of choice, which is 1B. Okay, so this is about the anti-arrhythmics, a summary. Now let's go to ECG. Okay, so I'm sure you all know the basic PQRS, T wave. Just to quickly remind you, P wave is atrial depolarization, QRS is when the ventricles are depolarized, and T wave represents the repolarization. Let's just start with abnormalities of the P wave first. So anytime you have a very tall P wave, like you see in this case, this is known as a P pulmonale, and this represents a right atrial hypertrophy. Whereas if P mitral is this bifid P wave, this is what we see in left atrial hypertrophy. Okay, so this is the first thing, P pulmonale and P mitral. Now let's talk about heart rate. So if you see the schematic here, you can see how one large square, yeah, you can see that this is one large square. It represents 5 millimeters or around 0.2 seconds. So one large square represents 0.2 seconds. So basically how heart rate is calculated is, you look at the number of large squares. So heart rate is going to be 300 upon the number of large squares which are included in between two RR intervals. So if I have to measure the heart rate in this ECG, it's 1, 2, 3, 4, 5 and almost 7 boxes. Alright. So this is 6 to 7 boxes. So this is lesser than 50. So this is definitely bradycardia. So anytime the number of boxes exceed 5, yes, anytime the number of boxes exceed 5, it means that the heart rate is less than 60. So that is bradycardia. Anytime the number of boxes are less than 3, that is tachycardia. So 60 to 100 is the normal heart rate. So less than 3 becomes tachycardia, more than 5 becomes bradycardia. So this, in a look, in a glance, you can quickly know whether you're dealing with a case of tachyarrhythmias or bradyarrhythmias in the exam. That's your starting point. So the first thing you're going to do is heart rate. Quickly glance at the P wave, see whether it's a simple P pulmonale or P mitral. So two things we've done. Now let's go further. So you have something known as the PR interval. Yes, so what is the PR interval? PR interval is, it is at the beginning of P wave to the beginning of the QRS. Alright, so that is PR interval, which is roughly 0.2 seconds. Then you have this QRS, which is the depolarization. So here we want to look at the QRS interval as well. So QRS interval is somewhere between 0.12 to 0.2 seconds. Wide QRS versus narrow QRS is going to help us, and we'll talk about that in arrhythmias. Once the QRS is over, you have this point here, which is J point. J point has to be isoelectric, meaning it has to fall at the 0 millivolt. Can you see this? So J point has to be isoelectric point. Anytime you see an abnormal wave at J point, There are two differentials. Let's just finish it right here. So now we were at J point. If you see 1 and 2 ECG, at the J point you see this wave here going up. This is the Osborne wave. Where do we see the Osborne wave? The diagnosis is hypothermia. Very important question. On the other hand, if you see this sort of a humping here, this is known as the epsilon wave. Alright, so epsilon wave, where do we see it? We see it in a familial arrhythmogenic condition known as ARVD. ARVD is arrhythmogenic right ventricular dysplasia, wherein you will have family history, you can have sudden cardiac death history. So this is epsilon and Osborne. So there are two waves. Based on the history, you will be able to diagnose. So whenever you see an extra wave at J point, this is about the two things. After that, you have the ST segment. This has to be isoelectric. If this is not at 0, this is up or down. This is ST segment elevation and depression. And then you have the T wave. What you see here from the beginning of QRS to the end of T is the QT interval. Yes. So this is the QT interval. QT interval normally is 0.4 seconds. Alright. But again, there is a correction here. So there is something known as QTC. What is QTC? Is a corrected QT interval where we take the QT interval upon the square root of the RR interval. Alright. This is known as the Buzet's formula, and anything less than 0.6 is normal. Alright. So we have these numbers. So you have 0.2, you have 0.4 and you have 0.6. Anything which exceeds this is enlarged or prolonged. Okay. So this is how we have the basics of ECG in place. Now, let's have a look at this very important ECG here. So, while we were doing the PQRS, what you are seeing here in this particular ECG is that the PRS is very much reduced, and suddenly you have an accessory wave, which is this slurring here of the upstroke of the Q wave. You have this shortened interval with this accessory wave that is known as the delta wave. So, here you have a named wave one more. So, we have Osborne and epsilon. Now, we have the delta wave with shortened PR and prolonged QRS. What is the diagnosis? We are talking about Wolff-Parkinson-White. In this, you have an accessory tract which is joining the atrium from the ventricle, and instead of going through the SAN to the AVN and then to the bundle of His, it's directly conducting through these accessory bundle of Kent, right? So this is known as the accessory bundle of Kent, which leads to arrhythmias here. So what you want to do here is the drug of choice in emergency conditions is going to be IV procainamide if the patient is unstable. Overall, medical management is by flecainamide, but the treatment of choice is ablate the accessory bundle of James, ablate that abnormal bundle of Kent. Okay, last part kar dena. Ablate the bundle of Kent. So this is about Wolff-Parkinson-White. So three conditions we've already seen. We've seen how to calculate the heart rate. We have seen two P wave abnormalities, right? So this way, baby step, we're going to gather all of the ECGs. Okay, so this is done. Now let's have a look at axis deviation. How do you calculate axis deviation? So remember, anytime you have a positive direction in lead 1 and lead AVF, these are the two leads you are looking at, lead 1 and lead AVF. So first upper and then extreme down is what you look at, 1 and AVF. So if both the predominant direction is positive, this is known as normal axis deviation. So this is normal axis deviation when both are positive. When you see that lead 1 is positive and lead AVF is negative, meaning they are leaving one another. Look at this. 1 is positive and lead 2 is predominantly negative. They're leaving. So this is left axis deviation. See, in any time the left ventricle, the left chamber is much larger than the right chamber. Okay. So this is LAD. On the other hand, if this is negative and this is positive, they are reaching out, isn't it? They are reaching out for one another. So when you see this, this is also predominantly negative. This is predominantly positive. They're reaching out for one another. This is right axis deviation. When both are negative, this is an extreme axis. Very rare. This is known as extreme axis. So this is about the axis deviation, as simple as it gets, leaving, reaching, extreme. Now let's go to the most important, that is tachyarrhythmias. We're going to make it very, very easy. So now remember this approach. Anytime you hear the word irregularly irregular pulse or irregularly irregular rhythm, the RR interval are unequal. Look at this. The larger, this is smaller, this is larger. Look at this. This is larger, this is smaller. There are two DDs. If you see no P waves are seen. So irregular absent P waves. One diagnosis only, we are dealing with a case of atrial fibrillation, so commonly asked. Atrial fibrillation management. What you want to remember, if patient is unstable, you do a cardioversion. This is at 200 joules. So cardioversion, remember, is a synchronized shock that you're giving, which is directed at the RR. Defibrillator, on the other hand, is unsynchronized shock. There is no RR to tell you where to synchronize. Okay, so cardioversion versus defibrillation we've done. If the patient is stable, you got to do a rate and rhythm control that is done via esmolol, which / ibuletide, and anticoagulation is something which is very important because in patients who have AFib, they have very high risk of thrombosis in the atrium, which can embolize. So that's a very common scenario. After AFib, you can have mesenteric ischemia, you can have stroke. So who should you give what anticoagulation? For that, the score has also been tested. We now have the modified CHA2DS2 VAS score. Alright, so that's the name. So here you want to remember, C is for congestive heart failure, H is for hypertension. Age more than 75 gets 2 points. Diabetes, stroke gets 2 points. Vascular disease, more than 65, sex category female. So this is your CHA2 V2 score as it was earlier called. So maximum is 9 points. What is the recommendation? Score 0, nothing is needed. Score 1, you just give aspirin, whereas score more or equal to 2, you have to start prophylactic and oral anticoagulation. So this is for the prophylaxis of further embolism or further thrombosis from happening. Okay, so this score we need to remember. So pretty simple. Basically, age and stroke is getting 2 points. Fine. So this is about AFib. Now, when there is irregular rhythm and the buzzword is multifocal P wave, you are seeing that different morphologies. There should be more than 3 morphologies of P wave. So when you are seeing that there are multiple P wave morphologies, the diagnosis becomes MAT, multifocal atrial tachycardia. So this is MAT, multifocal atrial tachycardia, and one of the coexisting factors here is going to be pulmonary disease. So there is associated COPD or pulmonary embolism that would be given. Drug of choice is unique, calcium channel blockers. We're going to give verapamil here. So this is done. Now, again, a typical spotter, you see these sawtooth waves. This is what we call as the sawtooth pattern. The diagnosis becomes atrial flutter. So this is atrial flutter. Again, it's managed like AFib exactly. So all you got to remember is the shock here is lesser in cardioversion. Everything else is same. CHA2 VS2 score applies here also. Okay. Very important when you see that there is a narrow QRS, but you are seeing a supraventricular tachycardia. So this is supraventricular tachycardia with a narrow QRS. So just remember these patterns here. This is PSVT, paroxysmal supraventricular tachycardia, because of an AV nodal reentrant circuit that is happening. The first thing you do here, multiple times asked, is carotid sinus massage. This will cause the carotid bodies to discharge a parasympathetic flow, and you will have a reduction and a cancellation of the AV nodal reentrant circuit. If this fails, you can give IV adenosine as we've discussed, but if the patient is unstable, you do cardioversion. This is very important because most of the students are in so much hurry to mark adenosine, they forget that if the patient is unstable, you have to do cardioversion. Okay, so in all 3 of these, cardioversion is the mainstay in unstable patients. In MAT, you have verapamil. Okay, so this is the most important tachyarrhythmias which are supraventricular. Now going on to ventricular tachyarrhythmias, the hallmark here is going to be V for wide QRS. When you see this very erratic rhythm, looks like a child has written something, this is VFib. You can't go wrong on this. This is ventricular fibrillation. Defibrillation is what you do in unstable cases. If patient is stable, drug of choice is IV amiodarone and lignocaine. So basically both are your drug of choice is what you want to remember. So this, if you remember, we've also done in the ACLS protocol. So first drug to be given is epinephrine, followed by amiodarone, followed by lignocaine if the patient is unstable. Okay. On the other hand, wide QRS complex, this is ventricular tachycardia. Then very important for the exam, when you see this axis which is polymorphic, this is what is known as long QT syndrome or torsades de pointes. So this is torsades de pointes, long QT syndrome. This wavering baseline is very important. So remember two congenital syndromes associated with long QT. So we have Romanov-Watt. So this does not have SNHL, whereas Jervell-Lange-Nelson has associated SNHL. So this is how that could be tested. So Romanov, no SNHL. The drug of choice for this is MgSO4. So many times asked in the FMG and NEET exams. It's so important. Can't get this wrong. They would give you frequent drug histories here. So what are all the drugs which are related to long QT or torsades de pointes? So you want to remember here, very important. We have already done class 1A and class 3 antiarrhythmics because they increase the QT interval. Apart from that, 3 groups of antibiotics are very important. So you have macrolides, you have fluoroquinolones, and you have chloroquine. So these are 3 very, very important antibiotics at least that you want to remember. So this is about ventricular tachyarrhythmias. Now let's talk about heart blocks. Okay, so in heart blocks you have various types. So here we just remember a few love stories and heart blocks are sorted. Okay, so that's how we're gonna remember. So look at this first one where the PR interval is just prolonged, it is fixed. So it's more than 0.2 seconds, but it is a fixed PR interval. So this is the kind of relationship between two people where they are going apart. Alright, their distance has increased, but they are still living together. So it's like a married couple or still married, but they've just grown apart. Alright, so this is your type 1 block because this is so common in marriages these days, right? That this is type 1 heart block. This is very common. Okay, so this is type 1 heart block. We've just increased the PR interval. Everything else is constant. Second is where a divorce happens or a breakup happens, where slowly you are growing more and more apart and then you just split. So what happens in this is type 2 heart block, and type 2 first part is known as the Wenckebach's phenomenon or the Wenckebach's heart block. So what happens here? The PR interval keeps increasing. Look at this. It keeps increasing and then suddenly it's gone. There is no P wave which turns up. So after that you are separated. So this is your type 2. So this is your second degree heart block of type 1. Alright, that's how we can better put it. So second degree heart block of type 1, which is Wenckebach types, whereas in second degree type 2 block, which is the Mobitz type of heart block, what happens is it is the worst kind of breakup ever, where one party thought everything is going just fine, but the other party suddenly just ghosts the other person. You don't show up. So PR interval was normal, everything was normal. Suddenly there is no QRS that follows the P wave. So there is just no contraction following a P wave. So this is your second degree heart block, which is called as type 2. So second degree type 1, second degree type 2. So this is how we have gone about the stories. And finally look at the third degree heart block. Third degree heart block is where both of them know that we have nothing to do with each other and they are just going about. Alright, so this is an open relationship where there's no issue. P is like I'm gonna do my thing, R is like I'm gonna do my thing. So the RR interval is constant and the PP interval is constant, but there's no relation between P and QRS. QRS is coming when it wants to, P is coming when it wants to. Okay, so this is your third degree heart block. So second degree and third degree heart block is what usually requires pacemaker, whereas first degree heart block and your second degree type 1 doesn't usually require treatment. Okay, so this is how we have done heart blocks. Alright, and finally we have one more type in which you are gonna have irregular rhythms, but now with bradyarrhythmias. Alright, so this is unlike MAT and AFib where it was tachy, here you have bradycardia with an irregular rhythm. This is known as sick sinus syndrome, very frequently tested actually. So here you're gonna have elderly patient. Alright, so an elderly patient, you're having this irregular rhythm. You can also have an abnormal morphology of the P wave. So this is a sick sinus syndrome. Alright, so these are all of our bradyarrhythmia causes. Let's just finish off bundle branch blocks. So now for this, the two main leads, like how for axis we look at 1 and AVF, now we have to look at V1 and V6. So here the mnemonic that we have is Marrow and William. So whenever you see that on V1 there is an M which is forming and there is a W which is forming in the V6, this is right bundle branch block. But when you see a W forming on V1 and an M forming on The V6, this is left bundle branch block. So these two words do the entire job for us here. Okay, so just remember marrow, Rose, M and W, William, Lase, W and M. Okay, so this is done. Now, a few important ECGs, very important is digitalis and very important is potassium changes. And very important is potassium changes. So remember in digitalis, anything which has a T in the name is going to be shortened. Okay. So you have shortening of QT interval, you have scooped ST depressions, you have T wave which is flattened. So anything with the T, either it is shortened or it is depressed. Okay. That's how we remember. The only thing is PR is increased. So we've done PR interval increase, two causes. One was our heart blocks and second is digitalis. Where did we see PR shortening? We saw it in Wolff-Parkinson White. Okay, so PR is sorted for us. That's all we need to compile for PR. Now, digitalis. So look at what happens when we have this scooped ST segment. So this is ST segment depression. Again, this is a list we are going to compile. So this is our first ST depression that we have found. So this is digitalis, and here this is known as a hockey stick, or somebody also calls this a reverse tick mark or a Salvador Dali mustache sign. So these are all the signs that you have with digitalis, the ST segment depression. So two important things we have learned here. PR increases, ST gets depressed here, QT is shortened. So anything with a T in digitalis is reduced. Fine. Now let's go to potassium changes. So hypokalemia, you want to remember underkalemia, and you are going to see a U wave. So U wave is what is the prominent finding in hypokalemia. Hyperkalemia is very important. So if you remember MI changes, hyperkalemia is the same. The earliest change in the myocardial infarction is tall T waves. That's the first change that we have in hyperkalemia. You start to have these peaked tall T waves and the PR segment also increases. After that, you have ST segment elevation. Same in MI, STEMI, you have tall T waves followed by ST elevation. Same thing happens here, except for the fact here you also have a P wave which is lost and QRS which is increasing, such that eventually it's become this long sine wave is what you're gonna see. You can also see VFib or asystole if it goes beyond 8. Okay, so you're not gonna survive this. So this is about hyperkalemia. So we just remember MI, tall T waves, ST elevation, and then there are sine waves. So what do you do in hyperkalemia? Very important. The emergent treatment is going to be either calcium gluconate or calcium chloride. What you want to remember is no role of calcium carbonate. Very important. So this will be there in your options, calcium carbonate, that's not given. Apart from that, what you want to remember in the treatment, we can also give insulin and salbutamol. Do you remember this? We have done this in endocrine, that potassium is scared of two things. It's scared of insulin, it's scared of salbutamol. It goes and hides into the cell. So there's going to be transcellular spread, and that is why you're going to have hypokalemia which results. So these can be tried next. If this does not work, potassium resins can be given, and at the end stage, if nothing works, we'll have to try dialysis. Alright, so this is about the management of hyperkalemia, extremely important. What about calcium? So if you understood the action potential curve, calcium is what is very important for maintaining the contraction. If that is not there, QT gets prolonged. So hypocalcemia, the QT gets prolonged. You're going to have a very slow depolarization and repolarization. So QT gets prolonged, but if it's hypercalcemia, too much action is happening, very fast depolarization will happen. So you'll have QT shortening. Okay, so this is pretty self-explanatory. Ultimately, it all boils down to hyperkalemia. Okay, so this is done. So now that we know this, now we go on to the most important category, which is ST elevation. Do we already know one cause of ST elevation? Yes, we do. That is hyperkalemia, and we know it mimics the same as STEMI. So now let's do the changes in MI, that is STEMI. So the first change is peaked T waves. I already knew it. Second is ST elevation. We already knew it. What you need to remember is there is going to be this convex up. Initially, it might look like a concave, but eventually it becomes this convex ST elevation, which is also known as the Pardy sign. Okay, so this is convex ST elevation or the Pardy sign. After that, what you have is the loss of R wave and this Q wave which forms. Remember, this Q wave is something which is permanent, it's going to remain, and this is known as a pathological Q wave. This is seen in two conditions. One is an MI, which is an old MI if you just see the Q wave, or an HOCM. So this is also one thing we've compiled about Q wave. So we've done P wave, we've done Q wave, we've addressed PR interval, and we're doing ST elevation right now. So this is done, and finally you will see T wave inversion later on. So eventually, if you just remember this, we are sorted. Another differential of ST elevation that you want to consider is acute chest pain with pericardial rub. If this is the buzzword, pericardial rub, we are talking about acute pericarditis. Okay, so we are talking about acute pericarditis. So here what we are going to be seeing is concave of ST elevation. So here it's not convex, but it is concave. In addition, in MI, what we are going to have is ST elevation happening in certain leads depending on which wall the MI has happened. We'll be talking about that, but this is localized. On the other hand, we are going to have a global ST elevation in acute pericarditis. So that's one thing. In addition, you are going to be seeing PR segment depression. Look at this PR segment depression. So that's also acute pericarditis. So three differences: concave ST elevation, global ST elevation, and PR depression. So two causes done, in fact 3 causes done if we take into account hyperkalemia. In addition, you can also have transient ST elevation in Prinzmetal angina. We'll talk about this, which occurs because of vasospasm. We can also see this permanent ST elevation in a ventricular aneurysm, which is one of the complications of MI. Okay, so this is important. In fact, one more differential I want to add here is Takotsubo cardiomyopathy. So Takotsubo cardiomyopathy is again a condition which can mimic STEMI. It can have ST elevation. In fact, it can also have troponin levels which are elevated. Okay, but when you do the angiography, there is no plaque here. So this is stress cardiomyopathy because of epinephrine adrenaline rush, and I'm going to show you the angiographic findings. So this is Takotsubo, which can also have ST elevation. Apart from that, one thing you want to remember is a familial syndrome with a sodium channel defect. So this is Brugada syndrome, which can have this coving. This is known as a coving or a coved up type of ST elevation. Okay, so this is what we have as ST elevation differentials are concerned. Hyperkalemia, STEMI, and pericarditis. The most important two types of mimics of STEMI would be Prinzmetal and Takotsubo, and you want to remember a complication, that is ventricular aneurysm, and then something extra as Brugada syndrome. Okay, so this is all about ST elevation. Let's just compile ST depression also. There's not much. So ST depression, we have already seen one was digoxin. We have also seen ST segment depression happens in non-STEMI is going to have ST depression. Okay, so this is about that. Now, this was about ECG. Now we go on to myocardial infarction. So I've tried my best to compile almost all of the ECGs, made it pretty simple for you to remember so that at least these we can pick out. Remember, in the exam, don't run after a systematic approach to ECG. That's very good for practice and for reading. You know, you can read the entire ECG Made Easy book, which is pretty simplified version of ECG again. And still in the end, you will not be able to do this entire sequence on any ECG that's given in the exam. So you need to build this pattern approach and this tick in your mind. Okay, let me see the heart rate. Let me look at P wave. Let me see if there is any epsilon wave or there's any problem with the J point. Let me see if it is Wolff-Parkinson-White. Okay, that's not there. Let me look at tachyarrhythmias, whether it's supraventricular, ventricular, whether there's heart block, whether there's axis deviation, whether there's bundle branch. So each of the slides which I've taught, that should be what is running through your mind. So those boxes need to be there. All right, that's how you should approach ECG. With that, we go on to myocardial infarction, or in general acute coronary syndromes. Very important. So I'm going to tell you how to approach a scenario which has been given to you and what do you do. So stable angina is where you have a fixed narrowing. All right, you have a fixed narrowing, and that is why anytime you are doing exertion, you will have chest pain. So this is only going to present during exertion. What about the troponin level? It is going to be normal. What about ECG? It's going to be normal. Is there any infarction? No infarction. So stable angina, remember, it's just going to be conservative management. The drug of choice is beta blockers. Alright, so beta blockers are our drug of choice, which reduce the myocardial oxygen demand. Now we go on unstable angina and non-STEMI. So what we have here is pain which could be on mild exertion or on rest. NSTEMI is on rest as well, whereas STEMI is also chest pain on rest. So this is what is similar to all of them. Troponin level is going to be normal in angina. So what is the difference? When I say angina and when I say MI, the difference is actually troponin. So whenever the word MI comes in, myocardial ischemia, from this point on you remember myocardial injury, troponin has to be raised. So when I read the word MI, by default trop has to be raised, whereas if it is an angina, trop has to be normal. On the other hand, ECG can be normal or it can show transient ST depression. So does non-STEMI ST depression, whereas there is going to be ST elevation as the name suggests in STEMI. Okay. What about infarction? There is no infarction in angina. In MI, there is infarction, and that is the representation of troponin. Why is it coming out? Because there is some sort of injury which has happened. So in non-STEMI, there is subendocardial injury which happens, whereas there is transmural injury or infarction that happens in STEMI. Very, very important. What about managements? So unstable angina and NSTEMI, we take them together. The problem, what happened here? The problem is the main coronary artery actually threw out these small emboli which are pretty rich in platelets. So these are these platelet plugs that have blocked these small vessels. Now, the main important point here is that if I give thrombolytic to this category, there's going to be further breakage of these emboli. They're going to further cause progression in this disease. And because these are platelet-rich plugs, they're not going to respond to fibrinolytics. So what is most important is that fibrinolytics should not be given in these two categories. They're actually contraindicated. So our main management here becomes anticoagulation, antiplatelet drugs which could break these. So what you want to give is the standard treatment here. So you can give them oxygen, you can give them morphine. So I'm sure you know Sona Mona. So you want to remember oxygen, morphine, you can give them nitrates for the pain, anticoagulation in the form of low molecular weight heparin, and you give them anti-platelet drugs in addition to statins if needed. Alright, so this is the management for unstable angina and NSTEMI. In STEMI, after the initial management, which is the same, wherein you give them oxygen, morphine, nitrate, alright, this is what you want to restrict to. You do not give them antiplatelets before starting the fibrinolytic drugs, alright, do not give them, otherwise the risk of bleeding increases. So you remember MONA here, morphine, oxygen, nitrates. As far as the management of non-STEMI is concerned, first is the conservative management. So you give them oxygen, you give them aspirin 375 mg. Apart from that, you can give them nitrates and morphine if needed. Alright, so this is about the initial management, and then you decide the definitive management based on the time at which the patient has come. So I'm going to go into this, but before that, one category we had left out, which is Prinzmetal angina. So even though the word angina is here, this is a very unique type of an acute coronary syndrome where the main pathophysiology is a vasospasm. Remember that there is no clot here which is blocking the outflow, right? So there is vasospasm. So here the pain could be at rest, it could be with exercise, it is variable. Troponin level obviously has to be normal, otherwise I wouldn't call it angina, right? Whereas ECG can show you ST elevation. Like we discussed, ST elevation can be there, but it would be transient usually. There is no infarction which results, and the management is calcium channel blockers. This is very important because this is unique. We're going to give them calcium channel blockers to protect against vasospasm, okay? And one differential which I have told you here is Takotsubo cardiomyopathy. So this we already talked about. This is Takotsubo. This is the typical appearance of the ventricle here. So what you are seeing is this octopus jar kind of appearance. Takotsubo literally means an octopus jar, where we see that there is this mid-ventricle narrowing, that there is hypokinesis of the left mid-ventricle. The left mid-ventricle is hypokinetic, whereas the apex is normal. The apex is spared, alright? So you are going to be seeing hypokinesis here. If you do the angiography, you're not going to find any clot or any plaque. Okay, so this is Takotsubo, occurs because of a lot of stress. Okay, so this is about the differentials. Now we go to STEMI per se. So before I go to STEMI, let's just address the biomarkers. So the most reliable, as we have seen, is troponin. This is the best biomarker that we have. Remember that it starts increasing beyond 4 hours. It starts increasing beyond 4 hours. From 4 only you can remember this is 0.04 nanogram per ml. The rise should be at least 2 times more than this. So this is about troponin. It's the best, and it is also now the best. The serial monitoring of troponin is the best for reinfarction. Earlier it was thought that CKMB is the best for reinfarction because look at the green line. The green line normalizes by around 24 to 48 hours. So it starts to reduce by around 2 days, isn't it? So this is why CKMB could also pick up reinfarction after 48 hours. But then now it's considered that serial monitoring of TROP-I levels is actually better. Okay. Apart from that, one more update. The earliest marker to rise is HFABP, heart fatty acid binding protein. So that's the earliest. Best is troponin, also for reinfarction. Okay. And we can also have an early peak of myoglobulin marked in orange. So this is about biomarkers. Now to the management that I was saying. We've done the initial MONA management. Now what do you do? How do you reperfuse the patients? And that is the treatment of choice. So nowadays PCI is what is the treatment of choice. PCI means percutaneous coronary intervention. So we want to do an angioplasty. Usually radial artery is the artery axis of choice. You take your catheters and you're going to go into the coronary arteries. You're going to put iodinated contrast and you will see whether there's any narrowing or not. Okay, so that is what is done. If there is narrowing, you can put in a stent or you can just do a balloon angioplasty. Okay, so this, if the hospital is capable of PCI, then that is what is done, and this should be as quick as possible. So the device time should be less than or equal to 90 minutes. So FMC device time, that is the first medical contact to device time, should be less than or equal to 90 minutes. That's the proposed guideline. Okay, so this is about that. If the hospital is non-PCI capable, so here you want to remember that if you can't do it, but you can send it to a PCI hospital. So first medical contact to device time is less than equal to 2 hours. You can send them such that in 2 hours this could be done. So you can refer them. So you transfer for primary PCI if the device time could be less than 2 hours. Alright, so this is 120 minutes. But if that is not the case, if that would be more than 2 hours, then you want to administer fibrinolytic within 30 minutes of arrival. So three numbers, 90, 30 and 120. Alright, so everything comes together nice. So 30, 90, 120. Alright, what is DDO? So DDO is basically door in, door out time. So if you're going to send the patient, send in 30 minutes. Okay, so this is very, very important. Types of MI can get you questions. So this is from Harrison's. Type 1 is a spontaneous MI which is happening because of any plaque, erosion, rupture, fissuring or dissection. So this is what is the usual kind of MI. Type 2 is MI because of ischemia, either due to oxygen demand which has increased or due to decreased supply such as a shock. Type 3 is sudden cardiac death with symptoms suggestive of MI. So sudden cardiac death becomes type 3. Type 4 is associated with PCI or stent thrombosis. 5 is with cardiac surgery, and injury is could be just troponin which is raised is injury, as I've already told you. So 1 is plaque, 2 is oxygen demand supply mismatch, 3 is sudden cardiac death, 4 is PCI, 5 is surgery. Alright, so this is just one thing you want to go through one time. So now let's go to localization. How are different chambers supplied and how do we localize which chamber stroke is there on MI with the artery? Alright, so this is very important, but for that you need to have a brief understanding of the coronary circulation first. Okay, so for localization of MI, we first need to understand the anatomy. Okay, so we are going to start with coronary circulation. If you remember, in anatomy, we've done a lot of vascular branches, but I didn't teach you this because we wanted to integrate with CVS. Okay, so let's start off from the aortic root. So this is the aortic root with all of these aortic sinuses of Valsalva. So there are these three sinuses. This is the right anterior one, and then you have right and left posterior. Okay, so this is the anterior cusp, which also is known as the right coronary cusp because this gives rise to right coronary artery. Then in the posterior cusp, I have right and left. So right posterior cusp is what is known as a non-coronary cusp, because there is no artery which arises from there typically, and from the left posterior we have the LCA which is arising. So this is a CT cross section which is showing you the origin of the two vessels, which is RCA and LCA from the coronary sinuses. Okay, so this is done. Now once the RCA is arisen, it is going to travel in the right atrioventricular groove. So this is the right AV groove from where the RCA is descending. RCA has 4 branches. So remember the mnemonic CAMP. Okay, so CAMP is the mnemonic, which are the 4 branches of RCA. So the first one is the conus branch. So conus branch is going to supply the outflow tract. After that, you have the AV nodal branch. So this is your AV nodal branch. Then you have M. From M, you always remember marginal, and you can see how it's AM. So this is the acute marginal branch that we have. Anytime you hear the word marginal, it supplies the free wall of the heart. Okay, so this supplies the right free wall of the heart. Okay, so this is acute marginal. And finally, you have P, which is very important, that decides the dominance. So when PDA most commonly arises from RCA in most people, this is known as right dominant circulation. Okay, so this is the posterior descending artery, also known as PIVA, posterior interventricular artery. So in the IV groove posteriorly, this vessel is going to course, and what is it going to supply? Very important, it supplies the posterior 1/3 of the interventricular septum and supplies the posterior wall of the left ventricle. Okay, so this is the PDA most commonly arising from RCA. Now we have the left coronary artery. As soon as it arises, it's going to divide into LAD and LCX. So the left anterior descending and the left circumflex immediately divides. The left anterior descending travels in the interventricular groove. So this is also known as the interventricular artery. Okay, so this LAD is going to have 2 main branches. It's going to have the diagonal branches and it's going to have the septal branches. The septal branches, as the name suggests, supplies the anterior 2/3 of the interventricular septum, because posterior 1/3 is already done. The diagonal branch supplies the anterior wall. It supplies the anterior wall of the left ventricle. Then we have LCX. So LCX has 1 branch, which is the obtuse marginal. The obtuse marginal is going to supply the free wall. Yes, so it's going to supply the free wall, which is the lateral wall of the left ventricle. So in a nutshell, now imagine heart as a box. Imagine the left ventricle as a box. So if this is the box, let's say this is the septum. Anterior 2/3 of the septum and the anterior wall are being taken care of by LAD. Alright, and then the free wall is LCX, and this posterior 1/3 and posterior wall is RCA, or basically posterior descending artery. So this is how you will know the supply. So this is what you want to remember, and then we localize it on MI. Before that, let's just finish off venous circulation. One question always comes that out of all of the veins, they'll give you this option as anterior cardiac vein, great cardiac vein, middle, small cardiac vein. Everything drains in coronary sinus except anterior cardiac veins, which directly drain into RA. So you can see how they're directly going into RA, as everything else is coming into the coronary sinus. Okay, so that's all you want to remember from MCQ point of view. Now let's do the localization. So these are the ECG leads. I'm sure you know about the ECG leads. Okay, so anteriorly we are placing these V1, V2. So these represent the anterior part of the heart. So anterior V1, V2, anterolateral V3, V4, further lateral wall V5, V6. Further lateral and posterior, we don't really use these routinely, but can be added, which is V7, V8, V9. So what does this tell you? If I have an anterior or an anteroseptal stroke, I'm going to have an ST elevation in V1 and V2. Which vessel? Anterior we know is LAD. If it is V3, V4, anterolateral, this could be LAD again, because that is what is supplying the anterior wall. Then we have the lateral, the free wall. So obtuse marginal. So this is LCX, that is where we localize, right? So V5, V6 is LCX. V1 to V4 lead ST elevation, the most common culprit artery, the widow's artery, is what is known as LAD. On the other hand, special, if you want to look at a posterior stroke, a PDA stroke, then we need to use special leads, that is V7 to V9, or it could represent as reciprocal changes in V1, V3, that is ST depression in V1, V3 with tall RVS. So this is important, that posterior circulation stroke stroke can give rise to reciprocal changes in the anterior leads. So this is sorted. What is most important for exam is what I have highlighted in yellow for you. Inferior wall supplied by RCA, base of the heart, which is RV, supplied by the right coronary artery, the acute marginal branches. So this is 2, 3 and AVF. Very, very important. These are the inferior leads, 2, 3 AVF. This is so frequently asked. So whenever you have a patient who's having bradycardia, this is also something that can result in bradycardia, because as we saw, RCA is also supplying the nodes, it's supplying the SAN and the AVN, and that's why you can have bradycardia here. The person can be in shock as well. Okay, so this is extremely important. Whenever you get this history of brady or shock and you see ST elevation in 2, 3 and AVF, you always want to remember RCA territory stroke. Okay, so this is how we've covered. 1 and VL are also your lateral walls. So this is also LCX along with V5, V6. Okay, so on the ECG, just to again very nice diagrammatic representation, 2, 3 AVF is RCA more importantly rather than LCX. This is your inferior stroke. If you have 1 or AVL, this is LCX. If you have the central leads V1, V2, V3, V4, that is LAD, and again lateral V5, V6 is LCX. So this is how you know on your ECG, wherever you're seeing the ST elevation, you can localize to the artery this way. Okay, I hope this is now looking simple. Now we go to physiology. Alright, so CVS physiology, very important. So you can be asked any of these curves, and you know, at the first look, it gives you this dreaded sort of a look that I don't want to do this. But then it's very simple. Once you understand it, it's not tough at all. Okay, so this is the pressure volume curve that you have. So on the x-axis, we have the volume, and on the y-axis, we have the pressure. Okay, so this is the normal pressure volume curve. Here, what they're gonna tell you is, tell me what are 1, 2, 3, 4 phases and what each of these boxes represent. So it's pretty simple. I am starting off with a higher volume. Yeah, so higher volume, the pressure is increasing, but the volume is not changing. So this is isovolumetric contraction, and then the volume reduces. So the phase 2 has to be systole. Yes, so what is phase 1? Phase 1 is the isovolumetric contraction phase of the systole, whereas 2 is the ejection phase of the systole, isn't it? So this is how we could see how volume changes. So this makes it the end diastolic volume, the volume that I started off with. After that, we are going to reach here to the end of the systole, and then I'm going to have phase 3, which is isovolumetric relaxation. You can see the pressure going down, and finally phase 4 is the filling in phase of diastole. You can see how the volume is increasing in phase 4, isn't it? So what events are represented as far as the walls are concerned? So the moment we have the systole which is starting, which wall has to open? This is where the semilunar valves are opening. Okay. On the other hand, at the end of systole, you have the semilunar valves closing. So this is where the semilunar valves close. After that, what is going to happen? Because of the filling in, you're going to have the AV valves open, and then here you have the AV valve close, and that is when you have the isovolumetric contraction begin, and then once it contracts, you're going to have it all go down. So this is how you can identify this curve. Now let's see what changes will occur if we change certain factors. So if I increase the preload, do you know the Frank-Starling law? What happens in Frank-Starling law? As you keep increasing the preload, or as the length increases, the contractility increases, right? So that's what happens in preload increase. So when the preload increases, look at this green line here, the green line, the end diastolic volume has increased, but what happens? The heart pumps even stronger and it reaches the same state. So when you increase the burden, if I tell you, you have one more subject to read, you're going to say, all right, I'm going to push much harder and then I'm going to finish it all. So that is again same thing as preload increasing and stroke volume increasing. What is afterload increase? The outside pressure has increased. So now the heart is not able to pump out a lot of blood. So what happens when the aortic pressure increases? Yeah, what's going to happen is overall the stroke volume reduces, and this will result in the end systolic volume getting increased. Yeah, so you can see how ESV has increased because we are only able to pump out certain amount of stroke volume because of the increased afterload. So what you want to remember, anytime you see the pressure volume curve becoming thin, Yeah, this is thin for stin. This is stenosis is what is your likely diagnosis. So when thin, it is stenosis. All right, that is what you want to remember compared to normal. On the other hand, contractility increasing, fair enough, we are going to have more contractility. So the end systolic volume actually reduces. You have pumped a higher amount of blood. The ejection fraction has increased. Okay, so this is done. So now I'm going to show you these four and you will tell me what is happening in each of these. Right now I will only tell, but in your houses you will also say. Okay, so what is this is the normal curve. What can you see? This is thin. So what is happening? The afterload is increased. This is like the afterload increased curve. So this is aortic stenosis. On the other hand, if you find that there is so much volume now, the preload has increased so much. What does this mean? It means that now whoever I was giving it to is giving it back to me. So left ventricle, if I am the left ventricle, I had pumped to the aorta, aorta is giving back to me. So this is aortic regurgitation, which is resulting in a very high preload for me. But what do I do with increased preload? I pump even harder and I reach where I was. Okay, so this is AR for you. Again, we are seeing a thinning. So this is mitral stenosis because it's the only one left. So what happens in mitral stenosis? You have a lesser amount of blood which is coming in. So look at this. The end diastolic volume is low because now there is stenosis happening. So not much blood is able to come out. So the end diastolic volume is low, and that is why you pump small amount of blood. So that is MS for you. And again, it's widened. So this is mitral regurgitation. So what happens here in mitral regurgitation? I am pumping. If I am the left ventricle, I am pumping out the blood during systole, but I am sending some of it back also, which is coming back to me. So again, what we are doing is we are overall pumping out a lot of blood. So what is the difference between AR and MS is in both of them, overall preload for me as a left ventricle is increasing because I am only sending the blood back. But the difference would be here, I end up with a lower end systolic volume because I am pumping some blood to aorta. I am sending some blood back to the atrium as well via the MR. Alright, are you getting this? So that's why the difference would be here, the end systolic volume is slightly greater. Even though the stroke volume is very high, the stroke volume is high, but still the end systolic volume is higher as compared to this. Okay, so I hope this is clear. So you can just solve this very conceptually. Now let's talk about the pressure curve here. We are comparing the pressure of the left atrium, the left ventricle and the aorta. Alright, so we have these three pressures. So left atrium obviously has the smallest pressure. It's just doing its own thing. It is increasing slight pressure. This is just like the JVP curve. We'll talk about it. Ventricular pressure increases during systole and then it quickly goes down. Aortic pressure is again very high during the systole, and you see this dicrotic notch where the AV valve closes. There you have this, and then you are gonna have a reduction. Okay, so what we can see here is that the aortic pressure is almost the same as the ventricular pressure in the systole. Now let's look at the diseases and try to guess them. So what we can see here, this is an instance where the LV pressure is more than aortic pressure. Means I am pumping, again I am the LV, I am pumping against a higher resistance, against a higher afterload. So this is aortic stenosis. When I see a very large pulse pressure, look at the drop. The drop is because I, being an aorta, I am having aortic regurgitation. Suddenly I am sending a lot of my pressure to the ventricle so that I get rested very early. So this large pulse pressure is a sign of aortic regurgitation, and this is what we know, right? The bounding pulse that we are seeing in AR, very large pulse pressure. Now the atrial pressure is increasing, means there is some problem with the mitral valve, isn't it? So when the LA pressure exceeds LV pressure, this is mitral stenosis. I am having so much blood, I am not able to do anything. I am under a lot of stress, but there is so much stenosis, I can't do anything. Pressure increases. MR, what happens? Mitral regurgitation. You're gonna have again the pressure is constantly increasing because I'm sending something back, it's coming back to me. So this is mitral regurgitation, and you're also going to have a tall V wave here. So this is how we identify based on pressure volume curves. Okay. Now, the most important, something that gets you one question in every exam is JVP. You can't go wrong with JVP. So on JVP, we are going to have these 5 waves. So let's start off with atrial contraction. So now we are all sitting in the right atrium and we are going to go on a roller coaster ride with me. Okay. So we are in the diastole when the atrial contraction is supposed to happen in the final phases of diastole. So the atrium is contracting. So we are going to have our peak. So we are all gonna move suddenly because our atrium is contracting. All right. So A wave is atrial contraction. Okay, so now our job is done. Now it's ventricular systole's time. So we are gonna chill out. All right. So our contraction has happened. Now I'm gonna take a break. So I am gonna start to relax and ventricle is gonna contract. So by the time I'm relaxing, there is one isovolumetric phase in the ventricle wherein the tricuspid valve is also closed and the pulmonary valve is also closed. So that time when the ventricle contracts, isovolumetric contraction happens, there's gonna be a bulge of the tricuspid valve. So suddenly some pressure. Again, we are in the ventricle, some pressure is coming from below, so we all jump. So this jumping is C, which is the tricuspid bulge. So C for C, this is the tricuspid bulge which is happening. Then you have X. What is X? X is relaxation. That is what we wanted to do, right? We have done our contraction, we wanted to relax. So you relax, you're relaxing. Just that bulge gives you one C wave. Okay. So now you've relaxed a lot. Now we need to take blood from the veins. So our filling in is going to happen. SVC, IVC are coming in, filling in. So what's going to happen? We are going to have more pressure now. So V is the venous filling which is happening, and then you have to give it to the ventricle. So now our turn comes. So Y is the emptying. So you give the blood to the ventricle in the diastole, and then you have that contraction. So we are back to A again. Alright, so this is about the different waves of the JVP. What will be asked to you are the different conditions. So where do we see a large V wave, a very large filling in? When I'm getting blood from veins, in addition the ventricle also decides, you take your blood back. What is this? This is tricuspid regurgitation. So this is very important. This is where you get a very large V wave. Extremely important, A wave. What is A wave? A wave is contraction of the atria. When would it have to contract very hard? When there is a lot of resistance. So either tricuspid stenosis, pulmonary stenosis, pulmonary arterial hypertension, or let's say tetralogy of Fallot which has pulmonary stenosis. When I'm working against a high pressure, a high afterload, I have to contract a lot, so the A wave becomes large. If I ask you where will I have absent A wave, where is it that there are no P waves for the atria to contract? Correct, it is atrial fibrillation. Yeah, so AFib will have absent A waves. Where will you have canon A waves? This is what is seen in AV dissociation. In complete heart block, we're going to have canon A waves. Okay, so these three A waves almost always gets you questions. Very, very important. Then, again very important is cardiac tamponade versus pericarditis JVP. So for this, we have a trick. In order to remember the rapid descent, you remember pay tax. So in pericarditis, you're gonna have a prominent Y descent. In tamponade, you're gonna have a prominent X descent. So this is what you want to remember actually. Even if you just remember tax, it's fine. Where is it that there is blunted Y descent? It can't be P, right? So it has to be T. So cardiac tamponade, remember, there is a rapid X descent, but there is a blunted Y descent. On the other hand, where do you have both prominent? That is constrictive pericarditis. So if you just remember tax also, it kind of does the job, because that's the only rapid descent that's happening in cardiac tamponade. So this you have to memorize, alright? So this is the true purpose of BTR, that is pay tax. Okay, so this you gotta remember. So now the scary diagram, which is the Vigor's diagram, which kind of brings everything together. So topmost part, if you realize, we've already done, isn't it? That how in systole, the pressure of the aorta, the dicrotic notch, and the pressure of the left ventricle increases, and we have seen the dicrotic notch, and this is the diastole. So we already know this. Do we already know the JVP? Yes, I already know in atrial systole there is A, then there is CX, and then there is V and Y. So we know this. Do we know ECG? We have already done ECG. So we know P is atrial depolarization, after which you're gonna have atrial contraction. You have QRS, after which you're gonna have ventricular contraction, and you have T, after which the relaxation happens. So this also I know. The only thing we have left out is the heart sounds. So you know S1 is when you're gonna have the closure of the AV valves. S2 is where you're gonna have the closure of the semilunar valves or the aortic valve. S3 is an early diastolic sound, whereas S4 is a late diastolic sound during the atrial contraction. So this is all about the Vigor's diagram. So the only takeaway here is this formula which kind of looks like Elon Musk's daughter's name. So this is what you want to remember, that first event is the P wave. So let's just see if we can make sense out of this. If you can make sense out of this, you can do anything in the world, isn't it? So P is the atrial depolarization. So we know this, everything is fine. Atrial depolarization. Once it has depolarized, we are going to have the A wave on ECG. We have the fourth heart sound if it is present, that's going to be here. Now QRS, ECG event. What happened? Ventricular depolarization. Ventricles are getting ready to contract. When they contract, systole begins. What is the heart sound? We have S1 which results. So we already know this S1, the contraction has begun. The heart walls have closed. You have the C and the X, meaning when the systole begins, remember we were in the right atrium and we said that okay, now it's ventricles drop, I'm going to chill. So we have the C wave because of tricuspid bulge in the isovolumetric contraction, and X is the rest of your systole. So we are still in systole. Electrical repolarization has now begun. So things are going to look up now. We are going to relax in the ventricles. So this is your diastole beginning. S2 has come, means this is the closure of the semilunar walls. The systole is over. Then you are gonna have DN. What is DN? This is the dicrotic notch in the pulse. So this is gonna correspond after S2. We have the V wave. So now the venous filling begins in for the atrium. You have the S3 at this stage, which is around mid to late diastole. And finally, you have Y, which is the emptying, the passive emptying of the ventricles, which is happening in the diastole. So this is how you have the various events. Do you think you have to memorize this? No. Once you understood this, I think you're going to be sorted. Alright. So just remember the ECG events obviously are going to take precedence. And after this, I want you to just see what is following. So between P and QRS, you have A4. Let me just do it with a different color. You have A4. Here, you have 1CX. You have 2D and V. 3Y. Lots of things happening here. Okay. So this is about the Vigor's diagram. Now, we've already done this, but let's just do the heart sound and some accessory sounds while we are at it. You know, we have S1 and we have S2. So this is the systole, and then we have a longer diastole. So I'm going to make this longer. So S1, we have the AV walls which are closing, which marks the beginning of the systole. And then I have the semilunar walls which are closing, which marks the beginning of the diastole. And again, the systole will begin. Okay, so this is what you want to remember as far as S1, S2 are concerned. Where is S4? S4 is here in the late diastole, just before S1. Remember, S4 is because of the atrial stiffening. Atrial stiffening is S4. Mid diastole, we are going to have S3. S3 is because of increased stress on the left ventricle. So we also want to remember that this could be in physiological conditions like pregnancy as well. You can see S3 in addition to cases where you have a lot of blood volume. So conditions like thyrotoxicosis, beriberi, AV fistulas, also you can have S3 in addition to heart failure. Yes, so CHF, congestive heart failure, where the heart is not able to relax, you're going to have S3. In addition, now let's remember two early sounds. So what follows after S1? What follows after S1 is the ejection click. What follows after S2 is the opening snap. Alright, so ejection click frequently seen in aortic stenosis. Opening snap frequently seen in mitral stenosis. So this is seen in diastole. Two mid clicks. So mid systolic click. Where are we going to see a mid systolic click? So this is a feature of mitral valve prolapse. Where am I going to see a mid diastolic plop? So this is what is known as a tumor plop that is frequently seen in left atrial myxoma. Okay, so this is the order. S3, S4 in the diastole, remember the plop, remember the opening snap, remember the ejection click and the mitral valve prolapse. Okay, so this is about the heart sounds and the order. Okay, so now we start with the different types of pulses. So what you're seeing here is a normal pulse. You can see this dichrotic notch as we've already seen. Where would you see this very weak, low volume, hypokinetic pulse? When the volume is low, right? So in conditions like aortic stenosis. Where would you see a hyperkinetic pulse? Where there's a lot of blood volume, isn't it? So lots of blood is pumping and then suddenly it's losing the volume. So this is your hyperkinetic or your bounding pulse that we've already seen with aortic regurgitation. So either the total peripheral resistance is reduced or you're having a lot of blood volume. So in conditions like wet beriberi, in conditions like thyrotoxicosis, when you have an AV fistula, you're going to have hyperkinetic or bounding pulses. Where would you have a pulsus alternans? Where you have one pulse which is very high and then one pulse which is very small. Beware, do not confuse this with electrical alternans. I have seen students make this mistake. Electrical alternans is a feature of fluid around the heart, cardiac tamponade. But pulsus alternans is seen in left ventricular failure. So what happens here? Let's say I am the left ventricle and this is the aorta. I'm pumping out some blood. I am already dead. I'm left ventricular failure. So, marte, I'm just pumping out some blood. Alright. Marte means I'm almost dead in English. Alright. So, I'm just trying to pump out blood with the failed ventricle. So, what happens? Somehow, I did this small wave which was there. Alright. So, somehow I made this effort and pushed out some blood. Now, a lot of end systolic volume is going to result. So, that means I have higher preload. Do we remember this? Higher preload means suddenly Frank-Starling law comes into picture and I'm going to give it my all. I'm going to give a high contraction. So, what happens? Now, I give a great attempt and I get a very good rank. So, this is the alternating pulse where you get a bad rank but then you give it your all and then it becomes increased. So, use pressure to your advantage. Learn from Frank-Starling law. Okay, so this is the left ventricular failure. Water hammer pulse or collapsing pulse is what we saw. This is what is seen in aortic regurgitation. So one more condition in AR, you're going to have a sudden loss of volume because you're sending it back to the heart. So this is AR. Now something which again everybody confuses is bigeminal and bispherians. Bigeminal pulse is where you have this main pulse and then you have one small pulse together. It's not like in the different pulse, it's the different height like pulses alternans. Within the same pulse, you have one more chota peak which is coming along with it. So bigeminal pulse is what is seen in arrhythmias. Alright, so you want to remember this is what is seen in arrhythmias or AV dissociation. On the other hand, bispherians is seen in high output cardiac failure or you have an element of AR plus AS. You have aortic regurgitation with aortic stenosis in both of these cases. While you're pumping out, during the outflow only you have obstruction, okay? That's why in HOCM basically, hypertrophic obstructive cardiomyopathy, because you have an outflow tract obstruction, you are going to have this. At the peak, you're going to have this depression. Okay, so this is bispherians. How to remember and not get confused is, do you remember how difficult trigeminal nerve course is in anatomy? It's the toughest. Do you remember how arrhythmias used to appear very tough before this? Yeah, so both of the tough things, bigeminal, that is trigeminal is tough, arrhythmias is tough. So that's how you can remember. Okay, so this is pulse types. Quickly going to murmur. So I'm going to show you the type and you're going to guess which murmur I am talking about. So first we are talking about systolic murmurs, meaning when the ventricle is contracting. So logically what could these be? It could either be during aortic stenosis where the heart is trying to pump out blood, or during systole, it could be when the ventricle is contracting and blood is coming back to the atrium, that is mitral regurgitation. So those are the options here. So when you have this crescendo, decrescendo murmur, this is the very, very important typical feature of aortic stenosis or pulmonary stenosis murmur. This is louded as the heart base and it radiates to carotid. So this is AS. On the other hand, you have a hollow or a pansystolic murmur, a blowing high-pitched murmur. This is mitral regurgitation. So MR is the loudest at apex and radiates to axilla. These radiations are very important. This TR obviously would be in the tricuspid area. Now, what do we see here? We have a mid-systolic click followed by which you're going to have a murmur. So, do you remember this? This is mitral valve prolapse, a mid-systolic click, and then you have a crescendo murmur. Again, this could be after the pulse, and this is best heard over the apex. Anything with the mitral valve is going to be best heard at the apex, okay? Then, a holosystolic murmur with a congenital heart disease, this is VSD, alright? So, VSD murmur is best heard at tricuspid area. This is something interesting. Now, two named systolic murmurs, a benign flow murmur due to increased cardiac output in peds is known as the Stills murmur. So, this is a physiological murmur that is seen in children. The sign is early systolic peak in tricuspid regurgitation or deep inspiration. So, when you do a deep inspiration in TR, the preload increases, so the murmur increases and it becomes early systolic. So, this is known as the Caravello's sign. Okay, so this is systole. Now, diastole. In diastole, if you are having an early diastolic decrescendo kind of murmur, this is aortic regurgitation, because now the blood is coming back, right? You have just started to relax, but then aorta says, no, take this blood back. So, this is aortic regurgitation, again high-pitched blowing. Opening snap, what do we remember? This is mitral stenosis. So, mitral stenosis follows the opening snap, and remember, reduced interval, not S1 but S2, reduced interval between S2 and OS increases the severity. This correlates with the severity, alright. On the other hand, one continuous murmur, systole, diastole. This is patent ductus arteriosus. Why is it occurring in both phases? Because the pressure difference between aorta, pulmonary artery is constant. It's not just systole, it's everywhere, alright. So, this is PDA. It's best heard in the left infraclavicular area. Few names for you. What is this early diastolic murmur in PAH known as? This is known as the Graham's Steele murmur. You can remember grandpa here, grandpa or Graham pa. Okay. Mid diastolic rumbling low pitch murmur in AR. This is Austin Flint murmur. This is Austin Flint, whereas in mid diastolic in ARF is Carey Coombe. Alright, so you want to remember, I don't take the F for ARF, I take it here, only one F can come. So, Carey Coombe is ARF, Austin Flint is AR. Okay, so these are the different murmurs. Now, let's do the maneuvers. This is where you get a lot of basic questions from, very easy. Now, anytime I reduce the preload, what do you think is going to happen to the murmur? The murmurs are going to reduce. The murmurs are going to increase if the preload increases. And there are always going to be two exceptions which behave opposite, HOCM and mitral valve prolapse. So, this is it. Preload reduction, how can it be done? It can be done by standing. It could be done by Valsalva maneuver. How do you increase the preload? By passive leg raise, suddenly lot of blood comes. Squatting, suddenly lots of blood comes. So, these are the maneuvers. Now, afterload reducing and increasing. So, remember, all of the murmurs are going to reduce on reducing afterload. They are going to increase on increasing the afterload, except HOCM MVP are always exceptions, but now you add something, AS. AS also behaves opposite. Okay, so afterload reduction by amyl nitrate, afterload increase by hand grip. So you usually get questions in this category. What about inspiration? More blood volume in the right heart. So the tricuspid murmurs are gonna increase. Okay. So, basically you can say that the right-sided murmurs are gonna increase, tricuspid as well as pulmonary. Okay, so they are gonna increase. Fine, so this is about murmurs and the maneuvers. Now, a few high-yield facts from CVS. So, first let's understand the baroreceptor reflex. So, here anytime you have a sensation of increased BP by two baroreceptors, which could be in the aortic arch or the carotid bodies. Remember, the outflow of aortic arch is by a vagus, whereas carotid bodies send the outflow by glossopharyngeal nerve. They reach the medulla at NTS. What's gonna happen here? They are gonna reduce the sympathetic outflow, increase the parasympathetic outflow, which is known as cardio inhibitory signal. So they send supply to vagus, which reduces heart rate and cardiac output, whereas the sympathetic system reduction is gonna cause a reduction in systemic vascular resistance and low inotropy, overall reducing the BP. Okay, so this is the baroreceptor reflex. So what we saw was anytime BP is high, eventually you're gonna have a heart rate which is low. So Mary's law says that BP is inversely proportional to the heart rate. Higher the BP, lower the heart rate, lower the BP, higher the heart rate, and that is what we see also. In shock, there is tachycardia. But what does Bainbridge reflex say? Bainbridge reflex says that when the venous return is increased because of the stimulation of stretch receptors, you're gonna have the afferent impulses through sympathetic nerve which inhibit vasodilator area, so vagal tone reduces. So overall, increased venous return leads to sympathetic increase which results in higher heart rate. So this is known as the Bainbridge reflex. A hai, so you remember this is mediated in the atrium, meaning venous return increased, heart rate is gonna increase. What is Bezold-Jarisch reflex? So Bezold-Jarisch reflex tells you that certain substances like serotonin, you have capsaicin, what these guys are gonna do is they are gonna make heart rate low when BP is low. So they are gonna be directly proportional. So this is Bezold-Jarisch. So they just ask you these named based questions here. You can just go through this. This is the fixed law for estimating cardiac output, that if we know the total oxygen consumption, oxygen in pulmonary veins, oxygen in pulmonary artery, then you can know the cardiac output. Okay, so this is what fixed law says. Two very important medicine things about pericardial disorders. Alright, so whenever you hear the term Beck's triad, you already know I'm dealing with cardiac tamponade. As far as pericardial disorders go, one we have already seen, which is acute pericarditis. A quick revision: you will have a pericardial rub, you will have acute chest pain, you will have ST elevation, which is global, and you have PR depression. Tamponade, you have the Beck's triad. You also have pulsus paradoxus. What is pulsus paradoxus? During inspiration, you are going to have a fall in the SBP by around 10 mm. If the SBP fall during inspiration is more than 10 mm, this is what is known as pulsus paradoxus. Alright, so this is seen in tamponade. This is also seen in this condition, which is constrictive pericarditis. So we got to know how to distinguish these two. Very, very important. Both have pulsus paradoxus. It is more common in CT, tamponade. Apart from that, you can also see this in pregnancy, in asthma, in pulmonary embolism. Ewart sign is a sign of dullness in the interscapular region that can be seen in tamponade. What does JVP show? Come on, now you are gonna memorize this and tell me. So do you remember pay tax? So X descent is what is rapid here, whereas the Y descent is blunted. On the other hand, constrictive pericarditis, both X and Y descent are rapid, isn't it? So this is what you want to remember. So whatever is in pay tax is rapid. ECG in tamponade is going to show you something like this. Look at this. One wave is bigger, one is smaller. So this reminds us of pulsus alternans. This is electrical alternans. So electrical alternans is the feature of tamponade, whereas in constrictive pericarditis, you have this thick shell of pericardium around the heart, which will cause a low voltage ECG. Okay, so this is what you want to remember. Very important. Most important thing I did not tell you is Kussmaul sign. Kussmaul sign is not seen in tamponade. When you hear this, you think constrictive pericarditis. This is a paradoxical increase in JVP during inspiration. You know, during inspiration, there is negative intrathoracic pressure. The venous return increases. So what happens? You have an overall reduction in JVP because blood is coming into the right heart. But here, because the heart is fixed, it doesn't have space. It sends it back. So this increase in JVP during inspiration is Kussmaul's sign. Okay. A few images from pathology that we want to wrap up. So in the first image, what we are seeing is known as the Aschoff bodies. Alright. So these are Aschoff bodies that you're seeing, and the kind of cells that you can see, these caterpillar cells. Look at how they look like a caterpillar, isn't it? So this is what is known as the Anischow cells. Okay, so these are your caterpillar or Anischow cells. There's a O here. On the other hand, now looking at these two hearts, what you can see is this dilated chamber. This is dilated cardiomyopathy, overall the most common, again very controversial. So this is the most common type of cardiomyopathy, few of the risk factors being alcohol, and you want to remember even ischemia can cause dilated cardiomyopathy. The genetic mutation associated with this is a titin mutation. Okay, so titin mutation is associated with the genetic form of dilated cardiomyopathy. Histopathologically, you are going to be seeing this ninja star appearance, the nucleus which is standing out, ninja star appearance, DCM. Also remember, this is one of the causes of peripartum cardiomyopathy. You will see this morphology. Okay, so in DCM, you have this systolic dysfunction which predominates because the heart is just not pumping well enough. On the other hand, when you see this banana shaped septum, you are seeing the heart chamber is so thickened, it results in this outflow tract obstruction. This is hypertrophic obstructive cardiomyopathy, a cause of sudden cardiac death. Very typical history would be given to you here in an athlete, and this is the autopsy appearance that you might be given. This is myofibril disarray. Okay, so myofibril disarray, there is a outflow tract obstruction. So I'm going to show you a video here of the echo and the MRI here to show you what happens. So now I'm showing you this echocardiography here. Look at the thickness of the valve, right? So this is what is showing you the thickness of the valve in the center. Yeah, and so here you can see in the first image of the echocardiography the central balloon like septal thickening. So this is the criteria actually for the echocardiographic diagnosis, where the left ventricular wall that you're seeing here on the left side, I'm unable to point, that is what is thickened, and the septum is more than 12 mm. And what is very important is the systolic anterior motion of the valve. So now the mitral valve is also gonna basically do an anterior motion that results in outflow tract obstruction, and these are two images which show that very well. So this here is the outflow tract, and you can see this sort of a movement of the valve. So this is blocking the outflow tract further, all right. So this is showing the outflow tract obstruction. This is systolic anterior motion is what is being shown. So this was about the cardiomyopathies. Also remember, in the congenital form of HOCM, we are going to have a myosin chain which is mutated, all right. So it's going to be a mutation in the myosin chain, and now we have a specific targeted drug to fight against the myosin chain or the genetic type of HOCM, the name of which is mavacamten, all right. So mavacamten is this myosin inhibitor that you want to remember. So a new drug update can be asked in INICT. Very important path question: what is the stain that you are seeing? So this is your TTC stain. A normal heart is gonna stain red, whereas if you have LDH which has leaked out because of MI, it's gonna bind to the TTC and it's gonna appear pale. So this pale area here is the infarcted area that we are seeing. A few drugs that we want to remember from pharmacology. So these are all which are very frequently asked. You know, we focus so much on other drugs of angina and all, but these are what are usually asked. So remember, ivabradine I is the funny channel sodium blocker, all right. So this is going to block the funny channels of sodium. What is nicorandil? K se remember potassium. So this is a potassium channel opener. What is a Rho kinase inhibitor? Rho kinase inhibitor, remember, is fasudil. Dil se yaad rakho, dil ka drug, alright. So Rho kinase inhibitor, fasudil. Neprilysin is the enzyme which causes breakdown of different substances like bradykinin, substance P, and further causes vasodilation. So this is neprilysin inhibitor. Remember the name, sacubitril, alright. So this is sacubitril. Metabolic modulator here is trimetazine. The name itself is going to show you meta, so that's how you can identify it's a metabolic modulator, and a metabolic modulator plus a late sodium channel blocker, it's gonna be ranolazine. So if all fails, just remember ranolazine. This is what is very frequently asked. This is basically used in refractory heart failure treatment. Okay, so these are all of the new anti-anginal and anti-heart failure drugs that you just want to remember the mechanism of. So what happens here with digoxin is that this sodium calcium exchanger is pumping the calcium out and bringing the sodium in, which is causing the activity of the ATPase pump, right? So when I inhibit this, I'm gonna have more calcium which stays inside. This efflux, this exchanger will not work indirectly, yeah? So you're gonna have more calcium and more contractility. So that's how digoxin functions. In addition, digoxin also increases the vagal discharge, in which process it can reduce the heart rate. So it can increase the contractility, inotropy, as well as reduced heart rate. So this is very important, and this also explains a lot of the side effects of digoxin, that is arrhythmias. So if AV block happens because of digoxin, it will lead to arrhythmias. Alright, very, very important. And what is the drug of choice which I have told you? It is lignocaine. Yeah, so lignocaine, and in refractory cases we'll have to give monoclonal antibodies such as digibind. So this is about the arrhythmias. Apart from that, it can have other cholinergic effects because it increases vagal output, and it also causes blurry vision. It can cause a disturbance of the colors as well. It makes everything look yellow. Okay, so digoxin, blurry vision, cholinergic output, and it can lead to arrhythmias. Also very important, it can lead to hyperkalemia. Alright, so there are few factors which increase the risk of its toxicity. So remember, hypokalemia and renal failure. These are two causes which lead to arrhythmia. So these are the risk factors for the arrhythmias that we want to remember. So these are the questions which have come from digoxin. Very important category is dyslipidemic drugs. So I've given you the mechanisms. That is what is tested. I'm sure from biochemistry we all remember HMG-CoA reductase inhibitors as statins. One very important side effect is myopathy with this, because it blocks the coenzyme Q synthesis as well. Yeah, I have taught you this in biochemistry. Ezetimibe inhibits the absorption from the intestine. Fibrates inhibit PPR alpha. Where have we learned PPR gamma? We've learned it in endocrine anti-diabetic drugs, right? Niacin inhibits the hormone sensitive lipase. Do you remember high court of LA? HSL is catabolic, whereas LSL is anabolic. One more very important effect of niacin is that it can cause hyperuricemia, it can cause hyperglycemia, and it can also cause flushing. Now this flushing is mediated by prostaglandins. That is why this flushing can be inhibited by NSAIDs. This is unlike the flushing of vancomycin, which causes the red man syndrome, which is mediated by histamines. Okay, so this is the difference here. Very, very important recent question, PCSK9 inhibitors. So we have alirocumab and evolocumab. Few more newer drugs from this also. If you thought this was new, these are further new drugs. So we have lomitapide, we have very difficult to pronounce these also. We have anacetrapib. You can just make out CETP, right? So this is what tells you. You can just make out MTP, right? So this is what tells you. Mipomersen, sen tells you antisense. Evinacumab is AL3P. So these are just a few new drugs that I've compiled for you. So just go through it. Or if everything fails in the exam, try to find out the mechanism from the name itself. Okay. Finally, what we want to discuss is the prophylaxis of acute rheumatic fever. This has also been tested. So if you just had rheumatic fever without carditis, you just need to take it for 5 years or until you are 21 years of age, whichever is longer. If there was carditis but no valvular disease per se, 10 years or 21 years. But if there was carditis with some sort of residual rheumatic heart disease, 10 years or 40 years. Okay, so you want to remember 21, 21 and 40. 5, 10 and 10. So there's only one repeat in each of these. Independent question, what are the prophylaxis indications before any dental procedure? What you can remember is ASD is not an indication. You could have prosthetic valves, prior history, any congenital heart disease which is unrepaired or incompletely repaired or less than 6 months repaired, or after transplant you have valvulopathy. So these are just things that if you hear once, you should be sorted. Lastly, talking about a few updates of the hypertension. So this is the definition. Remember, normal BP is 130/85, high normal BP is considered to be till 140 and 90. So grade 1 is 140 to 160 or 90 to 100 diastolic, or 160 and 100 is your grade 2 hypertension. So what you want to remember, the first line treatment, usually the treatment is indicated for anybody who is greater than 140 by 90 unless you have associated ischemic heart disease or heart failure, in which case you can start beyond 130 by 80. First line in patients who are less than 60 years is going to be ACE inhibitors or ARBs. But if more than 60 years, then it becomes diuretics or calcium channel blockers. Alright, so this is how the first line drugs are. Emergency versus urgency. So emergency is where you have organ damage. Very important, when organ damage results, that's an emergency. Without organ damage is urgency. So emergency means IV therapy, urgency means oral hypertensive drugs. So this is a list which I have compiled. The takeaway from this is, anytime you have anything other than heart which is getting affected, alright, it is something wherein you can work upon with labetalol and nicardipine. So these are your drugs here. So labetalol and nicardipine are the first line drugs for all of this. And most of the places you are gonna have a reduction which is required within 1 hour, where it's roughly 20% of the mean arterial pressure. On the other hand, if you have acute coronary event or cardiogenic pulmonary edema, you rely on nitroglycerin. So this is a brief summary of the hypertensive emergencies which could help you in the exam. So this is it for cardiovascular system. I hope this has been clear. You do get a lot of questions from ECG. In certain exams like FMG, sometimes you get at least 2-3 ECGs in the exams. So this is, I hope this helps, and thank you so much for watching.